Walawani, welcome. My name's Ian Campbell from Palliative Care Australia in Canberra on the lands of the Ngunnawal and Ngambri peoples. Welcome to Thursdays at 3, our regular series of conversations with people living and working at the end of life. Today we chat to a doctor with over 30 years experience in palliative care. Hello, Dr Jo Doran, how are you going?
Hello, I'm good, thank you, Ian. Lovely to see you.
You too. Let me fill in some of the gaps around that introduction. Jo currently works for the Gold Coast Hospital and Health Service as a senior consultant and is also an Honorary Adjunct Assistant Professor at Bond University's Faculty of Health Sciences and Medicine. Originally from the UK, as you probably heard in Jo's accent, she trained in London and completed her postgraduate training at Royal Prince Alfred Hospital and Prince of Wales Hospital, both in Sydney, before heading to northern New South Wales, beautiful part of our country, where she was Area Medical Director of Palliative Care for 13 years. As an advocate and champion of palliative care, Jo was a co-author on the first national standards for palliative care and palliative care service development models. Both documents continue to underpin palliative care service delivery in Australia today. In recognition of her contribution to palliative care, she was awarded the Palliative Care New South Wales Leadership Award by her peers, was nominated for New South Wales Woman of the Year, and was recently nominated as Mentor of the Year for her current role. But Jo's greatest love, however, remains the bedside care of patients and teaching, which is now the main focus of her work. Thanks again for being here, Jo. Really looking forward to this conversation. Jo, what I should have also mentioned in your impressive CV is that this September you'll also be MC of the biggest palliative care conference in the Southern Hemisphere, the Oceanic Palliative Care Conference in Sydney, around 1,000 delegates attending. How are you feeling about that gig in September?
I'm really looking forward to it, Ian. I think about it every single day, and
hopefully not nightmares. No, certainly not waking you up in the night.
No, it's not waking me up. I just think about it when I'm driving and things. I'm really looking forward to it. I've had a look at the conference program. It is so much for everybody. There's a lot there. It's really engaging. It's interesting, and we just had a mini conference in our health service for advanced trainees and allied health and nurse practitioners. And it's post-COVID, it's so nice to meet each other face to face. The energy was just lovely. People just so ready to re-engage and not do things online anymore. So I think the conference is going to be fantastic. I would strongly encourage you to, as soon as we've finished, sign up if you haven't already. There's a lot, broad reach, and I think it's going to be very engaging and intimate, even though there's going to be 1,000 of us.
I'm really looking forward to it, especially with you as our ringmaster in Sydney over 3 days. And as you say, registrations are now open. Head to the OPCC website for more info. But Jo, we're here to talk about you and share your wisdom and your work. What got you into palliative care? Here we are 30 years down the road. Where did this start for you?
By accident, Ian. As you mentioned, I was training in the UK, and by the end of my intern year, I was ready to leave medicine. I was absolutely exhausted and demoralized, and I was actually applying for jobs at the BBC because I thought I'd go in a totally different direction. But one of my friends was doing general practice training, and I thought, if I do GP training, I might be able to work overseas as a volunteer. So I thought I'll persevere with it. And I just about finished my general practice training in the south of England. And they said, you've got to do 6 months palliative care. And I said, no, thank you. Because I'd done it as a medical student, and I just thought I found it too hard, too distressing. But anyway, they said, no, you've got to do it. So off I went to the hospice in Worthing. And within a couple of weeks, I just thought, I found my tribe. It was just so full of surprises. The patients, it was just, I think the staff were so wonderful, but also there was so much fun, which was a real surprise. There was engagement. We were really making a difference. We were really having an impact with patients and families. And I was just surrounded by really fabulous people who were working hard, but in a team. And it was one of the first times that I really thought we're really making a big impact here. It was just quite the surprise. And I just thought, no, I feel very, very at home. Having said that, I felt very, very incompetent and very unprepared, but I could see this amazing landscape of people interacting on a very deep level with patients and families, which was like a foreign language. But I thought, I really need to understand. I really need to be here.
Jo, when you say you felt unprepared, was that as a clinician or as a human?
Yeah, thanks, Ian. Both. So I felt I could see people engaging on a very emotionally mature way, and I could see it, but didn't know how to do it. And I just thought, this is a really important part of living and engaging in the world. And I really, really wanted to have that ease watching these people do this fluently. It was so amazing. It just, I really want to be able to be in that space. I really want to be able to engage in that way in medicine, but in my own life as well.
Does working in palliative care supercharge your life outside of the workplace?
I think working in palliative care has had a really massive impact on my life. And, you know, so that emotional engagement, that emotional maturity, I really had to learn that. And that took me a very long time. But, you know, emotional maturity and spiritual maturity are very aligned in terms of, you know, the integrity of self and your place in the universe and how you interact with other people. So it's had a profound effect on my development as a person, and also in the spiritual realm, not necessarily religious realm, but trying to engage. I have a very broad view of spirituality, and an intimate engagement with a person is a moment of spiritual exchange in some ways. Yes. in the way I see it, and that can be very, very minimal, but it can have a massive impact. You know, I was listening to someone talk recently, and they were saying that we have like our time with patients who are facing the end of their lives is like 5% our interaction, but my goodness, we can have a very profound impact if we're masterly in our engagement with patients, even if it's only for 5%. You know, that's, you know, I say to medical students all the time, never miss the opportunity to be encouraging, you know, and you know, lift people.
Is that the sales pitch for working in palliative care, Jo? You reflected that as a student doctor, you were perhaps reluctant to go back into palliative care.
Very much.
But here you found your tribe, and now you're teaching palliative care.
Yeah.
What's the sales pitch to get doctors, nurses, allied health professionals working in palliative care, do you think? How do you make it attractive to your students?
I think, so we have lots of students who come and are reticent, a bit like, and hesitant, but I don't do a sales pitch. I just take them along with me on a ward round, or, you know, send them with our nursing staff, our registrars, who will do the sales pitch just by being the people that they are, and which sounds really twee, but you really have to embody it, and it's really engaging with patients on an honest, on a human level, and people see that interaction and see the difference that it makes. And also, you know, things like pain and symptom control, that's obviously part of our armamentarium, but it's really the patient interaction. They see that and the value that we can bring. And we've had many students who have become very interested in becoming palliative care clinicians, you know, allied health, nursing, and doctors from the experience of it, rather than, I can't do the sales pitch. We do the sales pitch, Ian. We do the sales pitch all the time to the general public. It doesn't sell it. What sells it is the experience, you know, in the society we live in. It's people saying things like, "You've been so helpful," or "I wish I'd known about you earlier," or, you know, "I wish I hadn't been so afraid of palliative care." And it's hard to do the sales pitch in a meaningful way. It's the experience that changes people's minds and hearts, really. If that answers your question, Ian.
It does, and I guess it leads to my next question, in that you've painted a really beautiful picture of the broad scope of palliative care. You know, a palliative care physician doesn't work with one part of the body like some of the other medical disciplines do. How do you go about helping people understand what the full scope of palliative care is? How do you explain it to people? You're at a dinner party. What do you do, Jo? How do you explain it to people?
But I jokingly have told people I'm a florist, or I've told people I'm a farmer in the past, because if you tell people you're a doctor, they show you lumps and bumps and things. And but palliative care, they just give you this very sympathetic look, or they'll go, you know, "Oh, that's old people," or, you know. So you kind of have to explain it. And the best way I explain it is to say, look, it's very, very rewarding, and it's probably a lot more than you think it is. And it's not just about, you know, the last few days. People think it's about the last few days still. There's so many myths out there, Ian. You know, I think we're struggling to get this message across. And I will say to people, it's not the last few days, it's the last few months. It might be even longer. I know I have two patients at the moment, young, with curable disease. I'm seeing them to help with the pain control. You know, so, you know, it's people who are not necessarily even you know, end of life, or have a terminal diagnosis. So I try and paint it as a much broader picture than that, and that it is rewarding. It does have its moments, of course. But I came across a metaphor, and I have to apologize for the person who said this because I can't remember, but it's palliative care is not the rain, we are the umbrella. And it's so meaningful because we understand the roadmap for patients who are facing the end of their life. We understand that terrain and the potholes and the hills and the weather. It's different for everybody, but we understand it. And so we can be like guides and shepherds. But of course, patients have to do this themselves, but we can certainly be the support, and we know what the weather looks like. We know the weather report. We can carry that umbrella and give people that umbrella. And I think that's such a great metaphor to use, and makes people understand it in broader terms, and makes it less scary, you know.
Jo, you mentioned the two young patients you're working with at the moment with curative diseases. People might be surprised that palliative care and curative care can work together side by side. Tease that out for me. Explain how that works.
Well, no one was more surprised than the patients themselves when palliative care came along. So you have to say, just to let you know, don't be scared by palliative care. We're experts. So I'm seeing both of those young patients, both in the 30s, and I'm seeing them because they've got cancer and they have really severe pain. Having said that, we've had a massive impact on their pain control whilst they're still going through active treatment to have curative disease. So again, that's another message, that it's not just doom and gloom and end of life care. It's really having an impact. You know, often you refer to a palliative care service, you're part of that palliative care service, but more often than not, you dip in and out of a palliative care service. So you might dip into the palliative care service because you have needs that have that, that needs expectation, but it's all sorted, and you dip out of it again and just get on with your life. So we're we're there often in the background, Ian, and sometimes we're there temporarily, and sometimes we're there for the duration. So, and I would say it's not, yeah.
I was just going to say, what you talk about there, dipping in and dipping out of a palliative care service, I guess can be especially powerful when someone is referred early to a palliative care service with their diagnosis, rather than those last days or weeks. That being referred to a palliative care service early in your diagnosis isn't perhaps the shock that people perhaps first interpret it to be. That, as you say, you guys are experts in pain management and all sorts of things, and it's a service you can dip in and out of as you go through this journey.
Yeah, absolutely. It's very hard to get that message across, and I think we live in a death-denying society, but we always have, forever. Forever. It's not particularly now, I don't think. You look at arts and history, and death is everywhere throughout the history of philosophy, art, metaphysics, religion, spirituality. We have death at arm's length now, where it's on the television and it's all around us, and not so much in our homes, which it was not that long ago, 80 years ago, not that long ago. And so now we have death at arm's length, and palliative care is associated with death. So it's very, very hard to get past that for patients. But I also think that referral to palliative care somehow means you have to give up hope for a lot of patients. And that is really difficult, because I think it's very, very hard to imagine a life without hope and having to acknowledge that this might be a possibility. But the reality is, when you get to palliative care, we don't talk about death very much at all, unless you bring it up. We talk about living and how to make the most, what's important to you, what do we need to do to make this happen for you.
Jo, you talk about that sense of patients perhaps giving up hope when they're referred to a palliative care service, and how wrong that is when palliative care is focused on life. But you can understand that human response. Is that also something that we need to work on within the health profession itself? I often hear of perhaps doctors and nurses seeing death as a failure.
Absolutely, yeah.
And doctors and nurses being reluctant to give up hope for their patients, and being reluctant to refer their patients to palliative care. Is there education we need to do amongst health professionals as well?
Absolutely, and I don't know how we change the philosophy of it, because the philosophy is really it's actually about optimism. And the palliative care, what you'll find in a palliative care team, which surprises everyone, is that we have a lot of fun, and we laugh a lot. We laugh a lot with patients. The irony is not lost on patients, and we are the most optimistic team in the hospital, in my mind, because we're taking something which on the surface looks terrible and really working hard to make it the best, and really engaging on a human to human level to make things possible. So I see it all the time, just for comfort cares, and I'm just thinking it's so much more than just, and that whole failure in medicine is ever present, even now in 2023. That death is a medical failure. It's very, very hard to shift from, and very hard to try and explain to people the value of death. There was this really important paper that came out last year from the Lancet about the value of death. And there are many good things about death, and one of which is it makes people step up, Ian. If you know someone in your community is really, really sick, people want to step up. We live in this very cynical world, and it's hard to do good. But if someone's really, really sick, people step up. The community raises funds. People want to be their best selves. They want to help out. And if we keep pushing death away as a failure, and of course it's not. It's actually the one thing in life you can't fail at. And the other thing is you get a certificate. So, yeah, I'm looking forward to getting my certificate. Right, you know. But there is value in really acknowledging people who are seriously ill and really paying attention to them holistically, and valuing the experience that they're going through rather than dismissing it. And we're still in that mire, unfortunately, in the Western world, certainly.
Jo, this question feels a bit tabloid. I hope you can forgive me, but you talk about the value of death. What's it like to be with someone who's dying, or to be with a family with a loved one that's dying? What's it like to be there?
I think a really important thing for people to know is that the vast majority of people die very, very peacefully. They die very peacefully, and particularly if they're referred to a palliative care service. And we give medication to make people comfortable and do our absolute best to not make people drowsy. So people think you're going to get morphine, you're going to be knocked out, they're going to increase the morphine, that's going to hurry things up. So all those myths exist. But the reality is getting people comfortable, allaying fears, having family present, having the dog present, you know, and trying to make a situation as peaceful as possible. So I am very often not present when patients die, because I feel like I'm taking away from the situation, unless of course there's stress there, and I can be of comfort. Mm-hmm. But it's a human experience, it's a soul experience, it's a family experience, and I like to try and leave the family to that and not be involved, as I say, unless that's going to be helpful. But people die peacefully. I think most people, by the time they're actually facing the last few days, are very accepting. Very, very accepting of what's going on. And I will ask people, are you afraid? And if you are afraid, what, can we explore that? And are you at peace? And people generally will say, I'm at peace. Even young people, Ian. So there's a lot of reassurance out there for people to understand that for the most part, it can be a very beautiful experience as someone leaves their body. Mm-hmm. Yeah. And it's a very spiritual and momentous experience. I went to see a patient last week actually, and I walked in the room and she said, did you work at St. Vincent's in Lismore? And I said, yes. And she said, you looked after my husband 17 years ago. And I thought, and she remembered all sorts of things in the conversation, and she remembered people. And it was just a nice reminder to me how important this is for family, and how important it is to get it right. And obviously, and it was a very, very positive experience for her and her family. And it was very, very humbling to hear someone say that for 17 years.
The mark you leave on people's life, and without knowing it, perhaps, and then you're reminded at opportunities like that.
Yeah, absolutely. Which is why I said, sorry, go in,
Sorry, forgive me, Jo. We're covering some big topics, and I hope you don't mind me throwing one more at you. But voluntary assisted dying is such a conversation in our community at the moment, and within the palliative care sector. Where's your wisdom at with this conversation? No doubt patients and families talk to you about it, perhaps.
Yeah.
And Queensland, where you're working, is down the road when it comes to voluntary assisted dying.
Yeah.
Where's it at in your mind? Share some wisdom with us.
I think so. For me, it's been a real challenge, Ian. So I have enormous respect for patients and families who choose that path. I personally don't feel I would ever be able to end somebody else's life. But I absolutely understand why people want voluntary assisted dying, and I have, as I say, respect for it. I think that it's an opportunity to say very clearly that palliative care and voluntary assisted dying are separate entities, that in palliative care we don't hasten people's lives, we don't hasten death, that we just, someone's here, they're going to die here, we just make sure that they're really comfortable. Mm-hmm. So voluntary assisted dying, when the first time it happened, we're 6 months into it, the first time it happened on the palliative care ward, the theory suddenly became real, and mm-hmm. it became visceral. It became sort of surreal, being 9 o'clock in the morning, knowing someone was going to die at 2 o'clock in the afternoon.
Yeah.
And they died with the clothes they chose, their family there, they had the beer, they had, they died peacefully, all the right things, which, palliative care, we want people to die peacefully and with care. And the same for voluntary assisted dying. It's just the mechanism of how someone dies is different. So it created a lot of stress, and the family wouldn't have any idea of that because of the professional nature of the nurses and the team involved, and the respect for their choices. But we felt it, and don't want to abandon patients that are known to us. We want to continue to care for patients and care for the body after the person has died, and care for the family. So it's something that sits very, very deeply with a lot of us, and has enormous amount of reverence. And I think the challenge now is to leave no person behind. So we don't want patients to worry that they're going to be involuntary euthanized, because voluntary euthanasia is now, or voluntary assisted dying is now available. So it's making it very clear that this is one camp, this is the other camp. It's very, very separate. So to take people who are very vulnerable and to reassure them, but also doctors and nurses and allied health who are uncomfortable with this are allowed to be exempt from the process, and their moral distress to be respected. Yeah. Sorry, that's quite a convoluted response, Ian, but it's a really, really difficult one, and it's not theoretical. When it actually happens and you see it happening and you witness it happening, it's very, very different from the theory. The reality of it, as I say, is visceral.
Not convoluted at all. I think you sum up beautifully the journey we're on, both as a sector and as a community, as this is implemented across Australia. This is something we're working out as we go and coming to terms with. Yeah,
absolutely.
Jo, one last question. I'm keen to know how you look after yourself. You've spoken of the power of your work and the influence of palliative care. That comes with a weight, I imagine, on you personally, a weight on your heart and in your head. And here you are, as we talk this morning, you're finishing a 3-week run of work straight. You're hanging to get to the weekend and have some time off. How do you look after yourself? What sort of self-care routine do you have so that you look after yourself so that you can provide care to others?
So I need to say that I have in the past not looked after myself, Ian, and I've been, I've been through phases where I've had to take, chunks of time off work where I've done locum work and things to just try and recharge my batteries. And the reason I say that is if, you know, people are working in palliative care and you're exhausted and you're feeling burnt out, you really need to look after yourself. And I've felt burnt out before, and I think that's such an unhelpful term because you recover from it.
Yes. Yeah.
And you know, you get rejuvenated again. And surrounding yourself with good people is one of the fantastic things that I've been very fortunate to have in my career is that I've worked in fantastic teams in every single palliative care service I've ever worked in, which is a joy when you go to work. And I think now I really have to try and look after myself as I'm in my 50s. And so I've started doing Zumba. And I absolutely love it. And I now do 2 minutes of Zumba with the whole of the service via Zoom every Wednesday morning. So if anyone wants to join in, just let me know. 2 minutes of Zumba, and everyone's on the screen. We've had, you know, the director of services, the director of nursing, as well as all the palliative care team. And it's just a really joyful event. It's very energetic. And I do Zumba twice a week, and I just love it. And everyone else has caught the contagion. So that's something that I really do. And then other things, you know, I've got my little nuclear family and my dog, and we go for walks and things like that. So I do try and look after myself, but I'm not the pin-up girl for self-care I would have to say, but I do my best.
You've learnt the lessons by the sound of things.
I've learnt the lessons, yeah. And everyone else, if you're struggling, look after yourself.
Find a Zumba class.
Come and join me for Zumba.
Jo, a real privilege to spend this time with you this morning. Thank you so much for sharing your wisdom and your work with us. And we look forward to seeing you at the Oceanic Palliative Care Conference in September in Sydney. And perhaps there's a Zumba class mixed in there somewhere as well for our 1,000 delegates.
You know, I'm just going to have to leave that as a surprise. But anything is possible.
Jo, enjoy your days off. You've worked hard for them. Thanks again for your time today.
Thank you so much, Ian. Lovely. And thank you. Lovely questions. Yes, I hope that's helps other people.
Dr. Jo Doran there, and registrations are now open for the Oceanic Palliative Care Conference this September in Sydney. Head to the OPCC website, and I'll include a link in the show notes, of course. Thanks so much for tuning into Thursdays at 3, whether it's via PCA socials or on Spotify, and engaging with matters of life and death. You'll find advice, tools and support at the Palliative Care Australia website, where you can also make a donation to support our work. We'll talk again next Thursday. Ta-da.